One of the most common questions I get asked as an orthopedic sports medicine specialist is what graft choice is best for me? There are two broad categories of anterior cruciate ligament grafts that we talk about with patients. One being your own tissue, and that is autograft. The other large category is what we call donor or cadaver grafts. And there's different things that people have heard about those things, maybe read on the internet, and each one of them has pluses and minuses. Certainly taking tissue from yourself has a benefit that it is your own tissue. And there are what we call bone tendon bone or patellar tendon grafts or your hamstring grafts. And each one of those has positives and minuses. The problem with autografts is that you're really robbing Peter to pay Paul. You're taking good tissue from one area of your body and putting it in to reconstruct an injured area of your body. So that certainly has risks with it. The patellar tendon graft, while certainly a very strong graft and at times has been referenced as the gold standard in anterior cruciate ligament reconstruction, there are risks with that. Some of the risks associated with anterior cruciate ligament bone patellar tendon, or the BTB graft as it's sometimes referred to, are fractures of the patella, because you actually have to take small pieces of bone on each side of the graft, a small piece from the kneecap and then from the tibia or the upper leg bone, and so those create weak areas in the bone. In fact, I've known several individuals who have actually had fractures of that when returning to activities. Now, fortunately, no patient of ours here, but certainly known individuals where that has been career ending. A lot of individuals are aware of a famous wide receiver, Jerry Rice, who played for the San Francisco 49ers, and that he ended up having anterior cruciate ligament reconstruction, had a patellar tendon bone reconstruction, and ended up suffering a fracture of his patella, which ended his career. Hamstrings are another form of autograft anterior cruciate ligament reconstructions that you can use, and those have pluses and minuses. One of the minuses is that we know in elite athletes at high flexion angles and at high velocity that there does appear to be some weakness at high velocity activities. Those hamstrings never grow back, and so you're removing 2 of the 3 or 66% of your hamstring tendons, and so that certainly can create some weakness. Intuitively, we would probably realize that. If you talk to any therapist, one of the most important things that we talk about in reconstruction of anterior cruciate ligament knees or deficient knees and after performing surgery are the hamstring rehab exercises. So you can imagine if that is so important, it's always, even as an orthopedic surgeon, made little sense to me that we would go and sacrifice those in order to reconstruct an anterior cruciate ligament. Now, there's certainly fine surgeons that use that graft as a primary graft, and again, you're a surgeon and you can decide what is best for you. And I certainly will use that graft if a patient feels that that is the best choice for them. Certainly my job is to inform them of the risks and benefits of each. One of the other large graft category choices we talked about early is that a cadaver or donor tissue. There's a lot of misconceptions about donor or cadaver tissue out there. One of the biggest ones is that they have a higher failure rate. The reason I think that allografts or cadaver grafts got a bad rap is many of these studies are what we call retrospective, and that means looking backwards. And these particular studies reference techniques that were done many years ago. The fixation techniques of how we attach the new ligament or anterior cruciate ligament graft to the bones, your femur bone and your tibia bone, are much different today than what they were many years ago when some of these initial studies with cadaver grafts were published. One of the other things that we realize and we now know is that if you actually were to do grafts that were treated with irradiation, that weakens the graft or the biointegrity is compromised. So most orthopedic surgeons that use any type of cadaver or donor tissue will use fresh frozen as opposed to high irradiation. If they do use irradiation, usually they'll use less than 2.5 or 2 megarads, as we say, and that has been shown to be the least damaging to the graft as compared to high dose radiation, which would be 2.5 megarads and greater. Certainly those early studies did not necessarily specify which of those grafts were irradiated, and so I think you can, in my personal and professional opinion, generalize and say that all allografts have a higher failure rate. We have found in our own practice and some of the studies that we share with our patients that allografts, if performed correctly, can have similar results to autografts. Certainly allow the benefit of not having to so-called rob Peter to pay Paul, and that is certainly a plus for many of our patients as well. Ultimately, your graft is something that you need to discuss with your surgeon, and ultimately you and him or her will need to decide what is best for you. Certainly those that are at higher activity levels may require a different graft than someone is at a lower activity level. Most of the time, people that have donor grafts or cadaver grafts do have less pain initially and usually will, in my experience, rehabilitate faster. Those that have autografts usually will have a little bit more pain and scarring early on, but certainly should end up at the same place as those that would have allo or donor cadaver grafts for their anterior cruciate ligament. So I think the bottom line is that you and your surgeon ultimately need to decide what is best for you. In my professional opinion, I think that donor or cadaver grafts that are fresh frozen and that are not processed with high dose irradiation are certainly a good option that one could consider. I hope this has been helpful. Thank you for listening in.